This is the first in a series of 3 lectures on respiratory medicine to help candidates for the Part 2 written MRCP examination. So we're going to start with a question on respiratory medicine. Question 1. A 27-year-old woman presents with right-sided pleuritic chest pain, which she says came on suddenly while she was lifting her son into his pushchair some 30 hours earlier. Her only medication of note is the oral contraceptive pill, and she is usually fit and well. She has very little signs or symptoms now and has not taken paracetamol for some 6 hours. On examination, her blood pressure is 120/70 millimeters of mercury. Her pulse is 80 per minute and regular. Her breath sounds appear normal, and her oxygen saturation on air is 97%. These are some investigations that she's undergone. So she's got normal hemoglobin, a white cell count of 8.2, platelets of 192, a sodium of 138, a potassium of 4.3, creatinine of 110. Her chest X-ray is abnormal though. She's got a small right-sided pneumothorax with a rim less than 1 centimeter. My question to you is, which one of the following is the most appropriate next course of action? I'll give you a minute to think about that. So if you chose send home with a plan for early review, you were correct. The others are incorrect. To explain this a bit further, this slide takes you through the management of a spontaneous pneumothorax. This came out in the year 2010 in the journal Thorax, and it was published by the British Thoracic Society as part of the pleural disease guideline. So first of all, the question you need to ask yourself is, was this a spontaneous pneumothorax? A spontaneous pneumothorax is one which occurred without any trauma. Now, obviously, in this case, there wasn't any trauma, so she has had a spontaneous pneumothorax. The next question you need to ask yourself is how unwell your patient is. So, is the patient hemodynamically unstable? If so, then there is no question. You need to proceed to a chest drain, regardless of the size of the pneumothorax. If the pneumothorax is bilateral, then again, you need to proceed to a chest drain. And obviously, our patient is not hemodynamically unstable, and the pneumothorax is only on one side, so that doesn't apply. The next question you need to ask yourself is this a primary or a secondary pneumothorax? So, how do we decide this? Well, a primary pneumothorax is one which occurs in lung which is undamaged and undiseased. A secondary pneumothorax is one which occurs in lung with pre-existing disease. So, if there's a history of pre-existing lung disease, or if there are features of lung disease on the chest X-ray, or if the patient is likely to have undiagnosed COPD, as evidenced by an age more than 50, or a significant smoking history, then assume that the pneumothorax is secondary to diseased lung. Now, our patient does not fall into this category, so she has a primary spontaneous pneumothorax. Now I would like to direct your attention to the left-hand side of this algorithm under primary pneumothorax. The next question that you need to ask yourself is, what is the size of the pneumothorax, and is the patient breathless? So if either of those criteria are fulfilled, you need to move to the right of the first yellow box, and what you need to do is do a needle aspiration. So this patient doesn't fulfill that criteria. She isn't breathless, and the size of the pneumothorax is actually less than 2 centimeters. And it's very important to remember where to measure the size of the pneumothorax, and that is at the level of the hilum. So in this case, you go straight down the left-hand side of the algorithm, and you consider discharge and review in outpatients with a repeat chest X-ray in 2 to 4 weeks, and that's the bottom left-hand box. However, should your patient require a needle aspiration, then you shouldn't aspirate more than 2.5 liters. And the box I want to direct you to is the red rectangular one, sort of just to the left of center. Okay, and once you've aspirated up to 2.5 liters, you need to re-X-ray and then assess the patient's breathing. And if the pneumothorax has diminished in size to less than 2 centimeters and the patient's breathing has improved, you can then send them home and review them again in the outpatients with a repeat chest X-ray in 2 to 4 weeks. However, should your aspiration fail, then what you do not do is repeat the aspiration. This is a big change from previous practice. What you do then is proceed straight to a chest drain. So the answer to the question success is no, and you go straight down the middle and you put in a chest drain. And the size of the chest drain should be small, 8 to 14 French, and obviously for this the patient needs to be admitted. So that was a summary of the management of a primary spontaneous pneumothorax. Things are a bit different with secondary pneumothoraces. So obviously the lung is diseased, so your threshold for intervention is going to be a bit lower. You need to ask yourself the question, what is the size of the pneumothorax and is the patient breathless? If the pneumothorax is less than 2 centimeters and the patient isn't particularly breathless, then you go down the extreme right-hand side of the algorithm. The next question you need to ask yourself is, break down the size further. So is the size between 1 and 2 centimeters? And if the answer is no, the size of the pneumothorax is actually less than 1 centimeter, then you can give a trial of observation. And what you would do then is, even if you're not intervening by aspiration or chest drain, you would admit the patient and put them on high flow oxygen. Obviously, you would not do this if your patient is carbon dioxide sensitive. The reason we give high flow oxygen is because it helps the pneumothorax to be reabsorbed. And then you observe the patient for 24 hours. Hopefully things should have resolved by the end of that and you will be able to discharge the patient. However, let's go back to the second rhomboid box, the yellow one, on the right-hand side. So the one which says size 1 to 2 centimeters. So say the size is between 1 and 2 centimeters. What do? You can then try aspiration. Again, it shouldn't be more than 2.5 liters, and you should do it with the Venflon. Should you succeed, and the size of the pneumothorax being less than 1 centimeter would be the definition of success, then you don't send the patient home straight away because the lung is diseased and there is a good chance it might recur. What you do is go down to the bottom right-hand corner and admit the patient again and put them on high flow oxygen, again, unless there's supposed to be a CO2 retainer, and you observe them for 24 hours. However, if you haven't succeeded, then you need to put in a chest drain. I just want to take you back to the first box below secondary pneumothorax, which is the more than 2 centimeters or breathless box in yellow. If the answer to that question is that yes, the patient is breathless, or the size of the pneumothorax at the hilum is more than 2 centimeters, you put in a chest drain straight away. Question 2 of this lecture is about COPD. So we have a 74-year-old male smoker with a 30-year smoking history. His FEV1 is 40% predicted. He has recently reduced his smoking habit to about 5 cigarettes per day, but unfortunately he can only walk 100 meters at a time as far as the end of the road, so his exercise tolerance is moderately limited. This is his drug treatment, so he's currently on an inhaled long-acting beta agonist and tiotropium. On examination, his blood pressure is 155/85. He has coarse crackles and wheeze throughout both lung fields. These are some investigations that he's undergone. So you can see that he's got a borderline low hemoglobin of 12.1, a normal white cell count, normal platelets, normal sodium and potassium, normal creatinine, but raised bicarbonate of 30. pH is normal. PO2, which is on air, is actually quite good for someone with COPD, is 10. And PCO2 is 6.4. So he's in chronic compensated type 2 respiratory failure. The question is, which one of the following 5 options would best improve his exercise tolerance? I'll give you a minute to just have a look at the options and think of the possible answer. Well, if you chose pulmonary rehabilitation, that was the right answer. I'm going to talk through all of the options and then discuss why the others are actually wrong. The reason it's not inhaled beclomethasone is that the role of inhaled steroids in COPD is mainly in exacerbation reduction rather than improving exercise tolerance. As far as inhaled salbutamol is concerned, well, these patients don't tend to have much reversibility, so short-acting beta-2 agonists really aren't going to improve this man's exercise tolerance by very much. Option C, portable oxygen, is not right either because this man has a very good PO2 on air. So it's unlikely that he would desaturate dramatically on exertion, so that option is wrong. Smoking cessation, obviously always advisable in COPD, however, the specific question here was, would it improve this patient's exercise tolerance? Now, his smoking habit is actually quite limited at the moment, so cutting that out completely would be good for him in the long run, but probably wouldn't do much for his exercise tolerance. So the answer is pulmonary rehabilitation. What I'm going to do now is just talk you through the new classification of COPD, according to the NICE guidance on COPD, which came out in 2010. And I know this looks like quite a complicated table, but all I want you to pay attention to is the columns on the left, so the first two columns, and the extreme right-hand column, which is the dark blue column. And then we can look at the classification. So if you look at the first column on the left-hand side, you have to have airflow obstruction to diagnose COPD. So your ratio of FEV1 to FVC needs to be 70% or less. In terms of severity of COPD, it's classified in terms of your FEV1 as a percentage of the predicted for your age, gender, and height. So if your FEV1 is 80% or more of the predicted for yourself, then you have mild COPD or stage 1. And this is a change in the NICE classification. This category did not exist before. If your FEV1 falls between 50 and 79% of the predicted value, then you have moderate COPD. 30 to 49% is severe, and less than 30% is very severe, which is a new category. It's worthwhile bearing in mind that the other change is that the FEV1 is now supposed to be measured after administration of a bronchodilator. There's one caveat to this though, and some patients who actually don't have an FEV1 less than 30%, but the FEV1 is actually anything less than 50%, would still be classified as very severe if they were to have respiratory failure. I'm going to come back to pulmonary rehabilitation now for a bit. So when would you offer patients pulmonary rehabilitation? Well, really, it's anyone who's breathless. So anyone whose breathlessness is impinging on their daily activities should be considered for pulmonary rehab. Obviously, it's not suitable for patients who are unable to walk, have unstable angina, who've had a recent MI. How's it delivered? Well, typically it's delivered in sessions which are 45 minutes to 1 hour long, and it's delivered once a week for approximately 6 weeks in succession. And patients find that towards the end of the course of rehabilitation, their exercise tolerance has typically improved quite dramatically. Question 3 of this lecture. A 71-year-old woman with a previous history of TB comes to the clinic complaining of lethargy, weight loss, night sweats, and intermittent hemoptysis. She has a history of hypertension, managed with ramipril and indapamide, but is otherwise well. On examination, her blood pressure is 142/87, she is apyrexial, her body mass index is 21, so she's a bit thin. Some investigations are undertaken, and blood investigations are largely normal. However, she has a positive aspergillus precipitin test. This is her X-ray. The question is, which one of the following is the most appropriate treatment for her? Okay, so if you chose surgical resection, that is the right answer. Let's go back to the X-ray and just discuss it. So you can see that in the left upper to mid zone, there's an abnormality marked by arrows. So you've got a circular shadow surrounded by a rim of air inside a further crescentic cavity. So in someone with a history of previous tuberculosis who comes in with a ball of something inside a cavity, they're most likely to have an aspergilloma. An aspergilloma is made up of the fungus Aspergillus fumigatus, and it tends to occur in cavities left by previous lung disease, most typically tuberculosis. And the crescent sign, which you see here, is supposed to be quite typical of this condition. I'm going to go through the treatment options and just discuss which ones are right and which ones are wrong and for what reason. Surgical resection is the best option for this patient as it has the highest chance of cure. So if your patient is reasonably fit and can withstand major surgery, that is the right answer. However, some patients, because they have poor lung function or have otherwise got other comorbidities, might not be candidate for surgery. In that case, you can try antifungal treatments, and your first-line treatment will be itraconazole. And if that weren't to work, you might consider drugs like voriconazole and amphotericin, but that would be very unusual. What can itraconazole do? Well, it will reduce the symptoms. It can reduce hemoptysis as well. In up to 60% of patients, it can actually shrink the lesion and even make it disappear completely. Bronchial artery embolization really is reserved for patients who have frequent or major hemoptysis. It's a palliative measure. Question 4 is on asthma. A 28-year-old woman with mild asthma since childhood attends a chest clinic. Her last appointment was 6 months ago, at which time her symptoms were well controlled on inhaled beclomethasone, 400 micrograms twice per day, with occasional use of her salbutamol inhaler when required. She now describes worsening of her symptoms over the last few weeks, with a dry cough and wheeze, particularly at night. She had also noticed some morning dipping of her peak flow readings. She otherwise feels systemically well. On examination, she was mildly dyspneic, but able to speak in full sentences. She was apyrexial with a pulse rate of 72, blood pressure 120/82, and a respiratory rate of 16. She had scattered expiratory wheeze in her chest, with good air entry bilaterally. Her peak expiratory flow rate in clinic was 70% of her predicted value. So the question is, which one of the following is the most appropriate step in her management? I'm going to give you a minute to look at all the options, and then we can discuss. So the answer is to add inhaled long-acting beta-2 agonists, option D. And to explain why this might be the case, I need to refer you to the British Thoracic Society and SIGN asthma guideline, which was published a couple of years ago. Before we talk about the asthma ladder, which comes from the British Thoracic Society and SIGN guideline on asthma, let's talk about what we mean by good asthma control. So the questions you ask a patient in clinic about their asthma control are 3. Number 1, how often do you use your salbutamol inhaler? If the answer is more than once a day, their asthma is not well controlled. Number 2, have you had to take time off work, or have you been unable to do your household work because of asthma? And if the answer to that is yes, then their asthma is not well controlled. And thirdly, have they been waking up at night with cough or wheezing? And if that's happening at all, then again, their asthma is not controlled, and what you need to look at then is stepping up their treatment, provided of course that they're complying with their existing treatment. So let us talk through this guideline. I apologize for the small print. I know it doesn't come out very well, however, if you go to the BTS website, it's all there and you can look at it. So let's start with step 1. That is for patients who have mild intermittent symptoms. And for those patients, an inhaled short-acting beta-2 agonist should be enough as sole treatment. However, if patients are having regular mild symptoms, then you need to step up to step 2. And what you add in at that stage is an inhaled steroid. The dose you use is 200 to 800 micrograms per day. And this is the stage our patient is at. Because if you remember, our patient was taking 400 micrograms of inhaled beclomethasone twice a day. So she's actually using 800 micrograms a day. Now, our patient is not well controlled, so we need to go up to step 3. And we need to add on some treatment. And the thing to add on would be a long-acting beta-2 agonist, such as salmeterol or formoterol. Once you've done that, then you need to take a pause and assess their control of asthma. If they've responded well and the symptoms are controlled, you can continue with the long-acting beta-2 agonist. If there has been some benefit, but you still don't have total control, then you continue the long-acting beta-2 agonist, but you increase the inhaled steroid to 800 micrograms per day if they're not already on this dose, because you remember in step 2 there was a range of doses. However, our patient was already on the maximum, so this would not apply to her. If there hasn't been a response to the long-acting beta-2 agonist, you should stop it, as with every medication that a patient does not respond to, and increase the inhaled steroid to 800 micrograms per day, again if they weren't already on this dose. Once they're on this dose of 800 micrograms of inhaled steroid per day, and the control is still inadequate, you need to give them a trial of other treatments, and the choices you have are really leukotriene receptor antagonists or sustained release theophylline. If the patient's gone through step 3 without benefit, then you need to go to step 4, obviously. And you need to consider a trial of high-dose inhaled steroid, up to 2,000 micrograms per day, which is quite a high dose, and you're getting to the stage now where patients may suffer systemic side effects of steroids. Apart from this, the other thing you can try is addition of some oral medication if that's not already been tried in step 3. So again, leukotriene receptor antagonist, sustained release theophylline, and very rarely beta-2 agonist tablets, which we don't really like to use very often. If the patient's on step 4 and is compliant and is still not controlled, then really you need to think about giving them maintenance steroid tablets. And it's not something we like to do, obviously, for the side effects of steroids, but sometimes it's inevitable. So you would keep them on the highest dose of inhaled steroid, that's 200 micrograms per day, and then you start them on oral steroids, but you'd aim to keep them on the lowest dose, which provides adequate asthma control. This is really the stage where you should be thinking of referring the patient for specialist asthma care, so they should really be referred to an asthma specialist, someone who has an interest in difficult asthma, to look for other causes of asthma which could be targeted, such as ABPA, for example, or other possible diagnoses, because it could be that the diagnosis wasn't all asthma and there's another cause for their breathlessness. It's worthwhile pointing out that when I'm referring to the doses of inhaled steroids, I'm referring to budesonide dipropionate or equivalent. So most inhaled steroids are equivalent across the board. However, there are some variations, so you need to look at BDP equivalents. Question 5, and the last question in this lecture, again on COPD. An 89-year-old patient came into A&E acutely short of breath. She admits to a 50-pack-year smoking history. Her husband, who is with her, has noticed she is more drowsy than usual and says she has been unable to use her inhalers recently. She has also had a recent myocardial infarction, and the decision has been taken to manage this only medically. She's had an arterial blood gas and 40% oxygen, and that shows a PO2 of 8.9 kilopascals, a PCO2 of 11, bicarbonate of 34, a base excess of 5, and a pH of 7.31. So the question is, which one of the findings would most convince you to institute non-invasive ventilation? I shall give you a minute to look at the options and then we can discuss them. Right, so if you chose pH of 7.31, that was the right answer, the others are incorrect. And what I'd like to do is just go back to the blood gas results and then we can just have a chat about them. So, you'll notice that a PO2 on 40% oxygen is 8.9 kilopascals, which is reasonable. The PCO2 of 11 is obviously very elevated, so she's in type 2 respiratory failure. Her bicarbonate and base excess are elevated, suggesting that she has chronic hypercapnia. Her pH is 7.31, which suggests that she's got a respiratory acidosis. Now what I'm going to do is discuss the indications for non-invasive ventilation with you. But before I do that, I just want to talk through the other options and explain why they are wrong. So it's worthwhile remembering that non-invasive ventilation for an acute exacerbation of COPD is not given unless the patient is acidotic. So a PO2 of 8.9 kilopascals on 40% oxygen, that's not really an indication. The PO2 is good, and having a low PO2 anyway wouldn't be an indication for NIV. Having a bicarbonate of 34, again, a lot of patients with COPD can have chronic raised bicarbonates, and that doesn't necessarily mean that they need specific treatment. It's just an indication that they've had CO2 retention for a long time. PCO2 of 11, while I accept that that is very high, unless the patient's acidotic, again, you wouldn't necessarily start NIV. No anaesthetist available to intubate for another hour, well, that really is inappropriate. If a patient needs intubation, they need it, and we need to find someone to do it. And if they don't need intubation, then you should start other treatments, such as NIV. So the answer is pH of 10.31, respiratory acidosis. So, just to summarize, which patients should have NIV in an acute exacerbation of COPD? So it's patients who have type 2 respiratory failure and are acidotic and have had an hour of maximal medical therapy. And maximal medical therapy is defined as regular salbutamol and ipratropium nebulizers, a stat dose of prednisolone 30 milligrams, or IV hydrocortisone if the patient can't swallow, controlled oxygen via a Venturi mask to keep the saturations between 88 and 92%, and antibiotics if indicated. And if they remain acidotic after this hour of maximal medical therapy, then you start NIV. However, there are obviously some exceptions, and if the patient's extremely acidotic when they come in, you might want to consider starting it straight away. It's just worthwhile remembering that COPD patients do very well on ventilators, so think very carefully about your ceiling of treatment in these patients.